No bones about it, osteoporosis. And as Andre had said, I'm actually from Minnesota, if you couldn't tell from the long O's. So Michigan, Minnesota, we're all in the Midwest. I went to the University of Minnesota, Minneapolis, where I got my Bachelor's of Science degree in Sport and Exercise Science. When I started college, I thought I was going to be a physician, and then I thought that's too long to be in school. Well, I thought about doing physical therapy, and that was not my calling, and ended up moving to North Carolina, where I started working at a hospital called Rex Hospital in Raleigh, North Carolina. When I was there, working around other physicians, especially in the emergency room, I realized I was right the first time. My calling was to be a physician. So I always said, better late than never. So I was fortunate enough to go to UNC Chapel Hill. So if you have any Tar Heel fans, I never went to a basketball game. I'm sorry, I never saw the Dean Smith Center. But I did have a very good education, and it actually led me into OB-GYN, which I kind of jumped into with both feet, and I'm glad I did. Once I started residency was in 2004, and I completed that at Greenville Memorial Hospital in 2008. And I saw a lot of pathology, mainly maternal, mainly a lot of OB, but GYN as well. Now, when I left in August of 2008, I then came to MountainView OB-GYN, as Andrea had said, and part of Baptist Easley. There is a picture up here, right here, of us groupies at MountainView. In case you don't know us, that is me on the far right with my short professional hair. I was trying to get a job, looked all professional. I got a job, now I don't know, reverting back. Next to me is Dr. Michael Fox. He has been at MountainView, I believe, for 13 years. Behind him and in the center is Dr. Randall Squires. I always say he's older than dirt and been there longer than dirt, but he's been there the longest in our practice, the most senior in our practice. Next to him is newer Dr. Hank Salter. He's not new to OB-GYN, but he is new to our community. He was in the Seneca area for a while before heading towards the beach. Now he's back again. And again, his name is Hank Salter. On the very end is one of our newer additions to MountainView is Jackie Freeman. She's a nurse practitioner. And the last person, hopefully they're going to put her right here, that's not pictured, is Dr. Lee Beasley. Dr. Beasley is well known to this area for giving obstetric office care to our OB patients. But she has also joined us and unfortunately did not make that picture. Like I said, today we're going to do a brief review of bone health and then how your bones actually focus on your health and impact your health. Roughly in the human body, on the average, there's 206 bones. Some people will have extra bones in their wrists and ankles or extra digits. That can happen. We do know all of us have bones that provide function and structure and protection. Function with our muscles, they allow us to move. They give our muscles a place to hang, so to speak, so they give us structure. Some of us are bigger boned than others, we say, in Minnesota. They also provide protection. Some of us, like we said, we have a hard skull, and again, some of us a little harder than others, but our skull provides protection to our brain. Our chest cavity, protection to our heart and to our lungs. Inside the bone, actually there has a production of fat cells, also of blood cells, things like red blood cells, white blood cells, that comes from the bone marrow. So that actually is an area of active making of cells, so it's a very metabolically active area. And then most importantly, probably that we really don't think about is this calcium source. Between the teeth and the bones, calcium, 90% of our calcium is stored in those two areas, bones and teeth. Well, why do we care about calcium? Well, actually, every cell that we have depends on calcium. There are multiple channels in cells, and I'm not going to get into kind of the science behind it, but calcium is required to do a lot of those cellular functions, whether it's cells in our eyes, cells in our GI tract, cells in our kidneys, all of that requires calcium. Calcium also is part of blood clotting. If we didn't have a good source of calcium, we wouldn't be able to clot our blood. Calcium plays a role in cell signaling, most importantly between neurons, back and forth. So if we didn't have calcium for those synapses, one nerve couldn't talk to another. And most importantly, what we always think about is calcium is needed for muscle cells to contract. So if we didn't have calcium, we couldn't move. If we didn't have calcium, our heart wouldn't beat. Our GI tract wouldn't peristalse. All those things would not work if we didn't have calcium going in and out of the cells on a routine basis. So it's definitely a big source of calcium. And again, I'm not trying to reinvent the wheel by giving you a good anatomy class, but basically bones are formed from cartilage. Cartilage begins when we're babies and is formed by what we call ossification, or basically hardening. Salts get mineralized, proteins get mineralized, and collagens, and these cartilage areas can start either in the middle or on the very ends. There's two different processes of making bone, but that's roughly how bone is made. When we talk about bone, there's two types of bone mainly that we divide it up into. One type we call the compact bone or cortical bone. So the compact bone or cortical bone, we think about that with our long bones, our arms, our legs. When the dog has that big, long, shiny white bone, that's cortical bone. That's that hard bone that we think about. Now that actually takes up about 80% of our bone mass. So most of our bone is hard cortical bone. The other 20% is something we call spongy bone or trabecular bone. That's the bones on the end here. It's the bone that's in our hip bone. It's the bone types that are in our back, okay, in our wrist bones. So it's not as compact. You can actually see it right in here. There's all these open, it looks like air-filled areas. They're actually not an air in there. It's actually got blood vessels and nutrients and other cells in there. So it's a very active area of the bone. And this will come and play a little bit further into my talk. Another schematic of bone structure, again, this hard cortical bone on the outside that we see here, made up of multiple areas we call lacunae. You don't have to know about that, but that's a bone element to it, versus this spongy bone, okay? Lacunae have blood vessels surrounded by bone to protect it. The spongy bone has blood vessels that weave all through in and out of it, and actually it does a lot of transfer of nutrients and other cells that go back and forth. So part of this bone structure, like I was getting into, is we do know that bone is dynamic. Thank goodness, because how many people in this room have ever broken a bone? Not many. Well, you guys are pretty stable. I mean, I'm a klutz. I have broken a lot of bones in my life. And it's a good thing that bone is dynamic because it will remodel and it will heal itself. We put it an immobilization or we rest it somehow, maybe with a cast. And over a period of time, all these cells come in and do something, whatever it is they do, and it works again. We have our strength back. How this happens, and again, I'm not going to go into great detail, but basically there's a type of cell called an osteoclast, and I think of them with a C, they're the chewers. They're going to chew up the old bone, or the broken bone, or the damaged bone. When they're done chewing that up, behind it comes something we call osteoblasts. They will lay down new bone. They're the bone builders. That's how I think about it. The B for builder and the C for chewers, okay? I did pass anatomy, I promise. Along with these collagen and proteins and salts, this osteoblast will lay down structure that we call osteoid, and over time that becomes hard and it actually will form bone. Another schematic here, we see osteoblasts down here, or excuse me, class, the chewers, digging up that old bone. Behind it comes these osteoblasts building new bone right behind it. And this process is happening on a constant basis, okay? Whether we've had known trauma, we had a car accident, we broke our leg, or as we're getting older, just the stress of every day and the things that we're doing may actually cause us to have weakened areas or pulled areas. This is continually happening. This is also the way we release calcium back and forth. So this homeostasis, or this back and forth, kind of the yin and the yang of the bone, continues without us really paying attention to it. Thank goodness. One less thing to worry about. Now, osteoporosis happens, and this is more of a pathologic problem with the bone, where actually this normal bone of the trabecular bone or even cortical bone will become less dense and thinner and ultimately weaker over time, okay? So the real word osteoporosis means porous bone, okay? Now remember, trabecular bone does have that, what looks like air-filled areas, but actually has proteins and blood vessels like I mentioned, and this is a schematic of, or an electronic micrograph of one. That's a normal trabecular type structure. It has these bridging areas here, these thickened areas, and there will be blood vessels going in and out of all this if you actually could see it in real time. Versus this picture on the right, where this has got a more thinner area, there's even some broken areas in here. Definitely, if you had to think about, well, I need to stand here or stand here, where are you going to stand? I'm not going to stand on that. That doesn't look very strong. Now this is just a one tiny little area, but if you think about it, osteoporosis tends to be a global problem. So if this is happening in the hip on the right, it's probably happening in the hip on the left, and it's probably happening in the backbone, it's probably happening in the arm bones. This osteoporosis does not typically target one bone over the other as far as where the bone is at. Overall, it is estimated that 1 out of 5 women over the age of 50, so 20%, will develop osteoporosis in her life. It's also estimated that over 50% of women, so half of women in this room, will over time have a fracture secondary due to osteoporosis in her lifetime over the age of 50. So this is why this is so important for us to talk about, which we'll get into a little bit later. But when you think about, at least I know several people that come to my mind right away that unfortunately have had, for example, a hip fracture. And what happens when they break their hip? They end up in a rehab. They get better, they get worse, and then they end up in the nursing home. So that can be devastating. So it's not so much I'm going to talk a little bit about this whole bone health, but what is the outcome of that poor bone health? And that's what we're going to get into a little bit later as well. Now, to define osteoporosis, we have 2 ways we can do it. One of which is testing, and us doctors, we like to order tests, okay? Fortunately, this is an easy test. No scope in the bottom, no, you don't have to do a bowel prep or anything. You just go in there, lay down for 10 minutes, and they do pictures and you leave. So it's not painful, it's not difficult, although that table is a little hard, I'll give you that, okay? So on that, which I'm going to show you a picture of a DEXA, in a minute, what we're looking for is what's the mineral of the bone, how dense do the bones look, are they at risk for fracture in the future, and is there some kind of disruption that we can see even through x-ray imaging, okay? Another way that we can diagnose things, and I should not ignore you people over here, fragility fractures. This is a patient of mine actually came recently to the office because she saw the orthopedic. It's unusual for a gynecologist to get a referral from a bone doctor. It doesn't usually happen that way. And she fell down her deck stairs going outside, and she broke her hip. And the orthopedic doctor looked at her and said, "You have osteoporosis." And she said, "Well, how do you know that? Because I've never had a bone density test. I don't know." Part of what we'll get into is what we call these fragility fractures. This is when someone falls from either a standing or a sitting position with very little trauma and breaks a bone that we don't expect to break. A prime example is a person who might be walking and all of a sudden they trip and they put that hand out like so, okay? We call that an outstretched hand, and they fall on that hand. It's not uncommon for them to develop what we call a Colles fracture. So they break the end of the radius here in their arm. Now, our body is actually made to tolerate those kind of falls. We felt like that all the time when we were kids and we didn't break nothing, okay? So as we get older, those bones get weakened, and that wrist fracture can be actually a diagnosis of osteoporosis in the right setting. Now, she actually subsequently, when she saw me, I did order DEXA, and he's correct. He's right. She does have osteoporosis, but that's something to think about. Another example I have was actually more personal, was my grandmother. My grandmother's 92. She lives in an assisted facility. She is not a complainer, and about 8-9 years ago was complaining of back pain. Something is wrong with my back. And again, my family does not complain about nothing. You got to be half dead before you can get out of nothing in my family. Just shut up and go, okay? But she was just fussing, and on the 3rd day she went and saw her doctor, and he did some imaging studies, and in fact she had 2 compression fractures in her back. 2 of this vertebrae, or 2 of her backbones, had become over top of each other and pushed on each other so hard that they broke 2 of those backbones. Now that actually happened, we don't know from any trauma, but probably from her day-to-day activities. Whatever she was doing the week or 2 before that, something had happened, and we don't know what. So here there's no trauma involved, and she got the diagnosis of osteoporosis based on that. Again, a schematic. This is another common area. I talked about wrist, I talked about back. The other area we always talk about is hip, because that happens a good bit where people get hip fractures. To the left, you see a normal, kind of healthy bone, this thick, compact, or cortical bone, lots of trabeculae here, nice, healthy bone, versus a osteoporotic hip bone, where you have a thin cortical area or the thin, hard covering. This makes this appear like the trabecular is thicker, but actually it's more vacant, and it's just the way the imaging came through on my PowerPoint. I apologize. But this area here is called the femur neck. Okay, this is kind of the hip socket, and the neck of it. This is a very common place that when people fall, they break this area right here. Okay, and because what happens, again, in that hip area, If we look at a schematic, this normal bone will be thick, dense, normal, trabecular or spongy bone versus osteoporosis where we see a lot of thinning in the walls of the bone and maybe even more gaps. And you can just see this just not, looks more honeycomb, doesn't look as strong. Looks like a honeycomb, yep. A lot of air in there. Now we still have blood vessels going around there, but it's definitely has retracted back, or what we call attenuated. Fancy word for it's getting smaller. Now this poor gentleman here has fallen down, as we can see, so we would say he had a fragility fracture. Maybe he tripped over the cat, I don't know. And what has happened here is exactly what we're talking about. He fell on his knee, jammed into his hip, and he has a femoral neck fracture. Now, fortunately for him, he didn't also get a Colles fracture, because look what he did, like we all do. That's why God gave us two hands, right, to catch ourselves when we fall. He tried to catch himself, and again, this is that outstretched hand, another area right in here that we see a lot of fractures. And again, I'm not a bone doctor, but that's my bone knowledge right there from that. But you can see how this could happen to any one of us tomorrow, walking in the kitchen, right? It can happen. So again, screening, this is the DEXA scan that we talked about. Here's our nice radiology tech. She's helping us. They do elevate your hips. They usually look at the hip area and the spine for imaging. It is two types of x-ray beams that come through, and with the use of the computer, it will generate these images here, because what it does, it gets rid of our subcutaneous tissue or our soft tissue. That's kind of our muscles and fat. That's a nice thing. If I could get rid of my fat, I'd be all about that right there. So I bet I look really good on a DEXA. That's what I think. If I'm going to look thin, it's going to be on a DEXA. Anyway, using these images then, what we come up with is something called a Z-score or a T-score. Now, if you've ever read anything in the newspaper or even had your doctor talking to you, we like to throw these terms around. Basically, clinically, we use something called a Z-score. Excuse me, a T-score. I went to say it the wrong way. T-score looks at what does your image look like compared to a young, healthy, normal 30-year-old. Okay? I don't want to be compared to a young, healthy, normal 30-year-old, but that's what we do. Because what we found is bones increase in strength and in density up until through our late teens, 20s, up until our early 30s. So we get our peak bone health is probably around the age of 30. Again, youth is wasted on the young. So once we get this image, where's your T-score you compared to that 30-year-old? If you are less than a -1, so a 0 or a plus number, you've got a normal mineral bone density, normal study. If you are in this gray zone between a -1 and a -0.25, we call that osteopenia. And some people call that thinning bones. Lay people say, oh, she got thin bones, thinning bones. Basically, there's some disease process going on, but it's not diagnostic of osteoporosis. Now, that being said, there are a lot of patients we're treating who have osteopenia because they have other risk factors. And we'll kind of get into that later. But that still is a group that you need to watch, okay? This additional testing, this kind of comes into play once you are diagnosed with osteoporosis. Your doctor may or may not decide to look at other things such as kidney function, liver function, a CBC looking for anemia to see if there's other disease processes going on. I also like to do two things. Ionized calcium, which is the free calcium. Remember I told you have lots of calcium bound in our bones and our teeth, but what's that free calcium, the calcium that's out there working in those cells, how high is that or how low is that? Also vitamin D, and vitamin D, you can't pick up a newspaper now without somebody talking about vitamin D. A lot of information on vitamin D. It's going to be the next best thing since, I don't know, estrogen, maybe, I don't know. When I can talk to you a little bit about it later, we don't know a whole lot about vitamin D. We know you need it for bone health. We know that it does have some other functions to it. It's been implicated, maybe it helps with preventing heart disease and plaque. It may help decrease the risk of breast cancer. I mean, again, everybody thinks this vitamin D may be the pro-hormone that helps everything. We just don't know. The data is just not there. But the reason I check these is it helps me if I go to my next step, which might be treatment. And I'll talk to you about a little bit about that. Because all the Fosamax in the world isn't going to help if a woman or a man is vitamin D deficient. You have to have all those building blocks in place in order to add your medications to try to improve things. So, who to screen? This is extremely debatable. The International Osteoporosis Foundation, the IOF, they have come out with some guidelines. This is also kind of under another area called the United States Preventive Task Force guidelines. they all kind of agree on this statement right here. Women over the age of 65 and men over 70. Now, unfortunately, gentlemen, a lot of people are forgetting about y'all. I don't know why. When it comes to osteoporosis screening, they don't think about men. All the information is really geared toward women, which is interesting to me because men still do get osteoporosis, okay? And again, you'll see women 60 and other with risk factors, and these are some of the risk factors that we can talk about. Unfortunately, early menopause, the person that a lot of times gets forgotten here is the woman who had a hysterectomy and her ovaries and tubes were taken out when she was 40, when she was 36. That is a woman who had early menopause, and she doesn't think about that. She doesn't consider herself as going through early menopause. People who are on certain medications, heparin and steroids, proton pump inhibitors, and some of the seizure drugs. Those are kind of the big four that I always think about. Long-term use of those. Bad COPD patient who's been on and off steroids all their life, okay? They will weaken bone. Heavy tobacco use, and I would also add in here heavy alcohol use, okay? Sedentary lifestyle, like we mentioned, bones are dynamic. They need stress to help them build. If you ain't stressing those bones, you're not making healthy bones, okay? Low body weight, and this one is mainly for women and men who are less than 127 pounds. Where they got that number from, I'm not sure, but that's what they refer to, less than 127 pounds. I don't have a whole lot of patients who are less than 127 pounds. But anyway, what you can't forget though, and the example is actually my mother. My mother is 65 this year. She did not go through early menopause. She did have heavy tobacco use in her life, which she's recently quit. I'm very proud of her. Very sedentary lifestyle. Doesn't matter how often I tell her she needs to exercise. I'm Shelly, I'm her daughter, I don't know anything. Even though I'm a doctor, I don't know anything. Yeah, hush, okay. But she has a BMI that puts her in the obese category. She's like, I don't have osteoporosis, so I'm not thin, I'm not skinny. She does, okay? Just because you're not thin doesn't mean you don't have weak bones, okay? So I just told on her, she probably won't be mad at me. Don't watch YouTube, Mom. And then the other people we want to look for are people who have, again, that fracture that we talked about, that fragility fracture that they've had, people who are on already medications, and we want to know treatment. Is he or she getting better? And then lastly, some women who are considering coming off of their hormone replacement. Now, just because I say this is a guideline, you can use this to screen with, does that mean insurance will pay for it? Not necessarily. Someone said no, yeah. Medicare will do the 65 and up, and if you're over in every 2 years. And that's just about, you know, the rest you kind of have to finagle. I usually recommend people call. It's worth a phone call. Some people will also, patients will ask me, well, what about the ultrasound or the wrist check or the heel check that they do in the malls and stuff? Really, the World Health Organization for treatment values and for diagnosis, they just all default to the DEXA. We just don't have guidelines. How do we use that information? I think it's interesting. I wouldn't treat based on that. I think I would want a full DEXA. So, you know, I would do it. It doesn't hurt anything. You're walking through the mall, check your heel. But I personally wouldn't give a medication that could have complications if I don't have a true diagnosis. So I still would want the DEXA. Risk factors, like kind of what you talked about before, this is especially comes into a role for that patient who has osteopenia, the thin bones, not quite osteoporosis yet, but they have some risk factors, okay? This is where I fall in. I love my Diet Coke. Diet Coke leaches calcium from the bones. Any kind of caffeine does. That's a bummer. I thought I was doing really good. I'm like, oh, no. I exercise. I'm a Zumba person. Anybody does Zumba? Come with me. I love to Zumba. And then I hit caffeine. I thought, oh, uh-oh. Well, I do have, and I'm a white female, so I've got these risk factors. So right away, I could be considered to have a DEXA scan if I had, you know, reasons, and if I was over 50. I'm not over 50 yet. Not yet. Okay. Treatment. This is something that we can all do. This does not take a prescription. This does not take anything fancy, okay? Calcium. What I have actually done on my way here, and I know you've all had dessert, I'm gonna pass them around. You can help yourself. I just bought these. They're brand new. You don't have to have one if you don't want one. This is Viactive Chews. This is my way of this is how I take calcium, okay? Viactive has both calcium and vitamin D in the one chew. This is a caramel flavor. This is the chocolate flavor. Now, the other thing, however, if you were on Coumadin, this has vitamin K in it. So, I'm sure anybody who's on Coumadin knows, or doctor said, be cautious of vitamin K or collards or anything that can throw your blood out of whack. So if you're on Coumadin, I probably wouldn't take this because it does have a little vitamin K in it. But if you want to try one of these chews, help yourself. They're on me. One tastes like chocolate. One tastes like caramel. There's plenty. I've got another box, so you can definitely try them if you want them. Usually what I recommend is if you have a pretty okay diet, 1 calcium chew a day, whether it's Viactive or this is actually what my husband uses. Where am I here? Tums. Okay, we all have Tums in our house. My husband has too much beer and pizza, and he reaches for his Tums. I'm like, oh, honey, you're getting your calcium. No, he doesn't think about that. Now, I think, too, there's a newer Tums that has vitamin D in it. Now, this particular one does not. What you have to be cautious of, people who have a lot of heartburn, and if you take a lot of Tums, you will find this will make you constipated. Too much calcium is not always a good thing, okay? So calcium and vitamin D. It's nice, like I said, the Viactive, you get both in one chew. And if you're ever taking a calcium pill, it literally is about that big and it will gag you. It is the biggest, horsiest pill I've ever seen in my life. And it gags you. Weight-bearing exercise, 30 minutes most days. Hopefully all the family physicians are also talking. I'm big into overall weight control and weight loss. We are not exercising enough. We are way too sedentary. We used to say exercise 30 minutes a day for 3 times a week. Really, the shift has changed because we're not getting anywhere. If anything, the society is getting bigger and less healthy. So we are saying 30 minutes most days of the week. And I mean most. And I will get in anybody's face if they say, I'm not. No, you're probably not. And that weight-bearing exercise is not just like my mother who likes to swim and likes to ride her bicycle. I think that's wonderful. It's great activity, gets her out, gets her social. It's not helping her build healthy bones. Walking is a beautiful exercise for weight-bearing. The rubber bands, the elastic bands. You don't have to have big, heavy, clunky weights. You can take elastic band, put it around the doorknob, and you've got some resistance training. That's all it takes. Okay, I think those bands are like $4 at Target is where I bought mine at. Oh, by the way, those Viactive chews, they're like $9 at Rite Aid for that little box. I was surprised, but it has 60 in it. The other one was $9.99 or $10 at Target, and that's double the box. So usually, yes, ma'am. Excuse me, I didn't hear.
How many a day do you have to take?
Good question. The question was, how many of these do you take a day? Like I said, if you've got a pretty okay diet with a little bit of milk, a little bit of dairy, and I'll show you, well, here, we'll go right into that calcium, a little bit of the cheeses, you could probably start with just 1 a day, okay? Now, if you're a patient that I'm going to treat and I find that your vitamin D, for example, deficient, a lot of people are okay with their calcium. The vitamin D is the big one that we don't get enough of, and I'll get there in a second. But usually, sometimes you even have to go to injectable vitamin D, okay? It's a shot or a pill once a week. It's high dose. It's 50,000 international units a week. But I would start with that, just 1 a day, up to 2 a day at the most. And titrate, again, too much calcium, constipation. And if you're prone to kidney stones, sometimes calcium will also flare up kidney stone formation. Other areas, I didn't know sardines had calcium in it. I was surprised. You know why it is? They have bones in them. Yeah, I learned something. I was like, really? No wonder I don't eat sardines. But anyway, so fish, I love salmon. We have a beautiful salmon. I don't know if you ever had salmon here in the cafeteria. It's very good. Apricots, oranges. Now, these don't have a ton of calcium, but it's some. Okay, so when you're thinking healthy food, I'm a member of Weight Watchers. Oranges is one of our power foods. There's nothing bad I can say about an orange. I love oranges. Now, orange juice, high in calorie. Watch orange juice. Eat the orange. Lots of sugar if you're a diabetic. That's right. Calcium fortified foods, we think of the breads and the cereals. Most of our breads and cereals now get enough calcium in it. Vitamin D, on the other hand, I need to speed up, is a little bit trickier. We can get it from our diet, but the main way we do get most of our vitamin D is through the sun. If we get exposed roughly 15 minutes 3 times a week, sun exposed area, arms, legs, head, vitamin D becomes a pre-vitamin in our body. It does some changes through our liver and through our kidneys, and it comes in active form so we can use it for bone formation. Now, people who have liver trouble, people who have kidney trouble, they have difficulty with vitamin D. So that's somebody, again, like we said, we did those lab testings. That's why I'm looking for their liver function and their kidney function, because I want to see how well do they process vitamin D. Other people who have trouble, people who don't live in the sunny South like we do, people who live in a rainy state. My girlfriend lives in West Virginia. It is the most cloudiest place, apparently, in the United States. So she has less vitamin D exposure. People who are darker skinned, Hispanic people and African American, it's harder for them to absorb because they have more melanin in their skin, so they don't absorb the vitamin D. So they may actually have to be in the sun a little bit longer. Now, your skin doctor is not going to like me, but I do think that you should have a little bit of sun exposure. And usually after 10 minutes or so, then put your sunscreen on. Okay? It doesn't mean you get to be out there in the yard all day without sunscreen. 10 or 15 minutes, and then put your sunscreen on. Okay? That's usually what I recommend. Now, of course, the skin people your dermatologist will say, please put your sunscreen on first before you even walk outside. You get better coverage, it soaks in, you're better prepared. And I think there's something to that, but as far as vitamin D goes, I think it's nice to be prepared a little bit beforehand. I'm not going to spend a lot of time on treatment because I think this is a conversation that I'm running out of time, and you should have with your doctor. If in fact you are diagnosed with osteopenia with risk factors or osteoporosis and you're considering medical treatment, other than the supplements like we talked about and the diet and the exercise and things like that. These medications are broad categories. Bisphosphonates are the most common one. We know Sally Fields, for example, likes to talk about Fosamax. She thinks that's the best thing, or excuse me, Boniva. She loves her Boniva. Which it's nice to put a face with that because again, she's a thin, I'm sure she's probably less than 127 pounds, Caucasian woman. Right there, she could be the poster child and literally is for this particular medication. These medications, they're typically taken orally, whether it's daily, weekly, or monthly. They most common side effects can be some GI upset. That can happen with those. There's also a little bit of buzz in the media about this jaw necrosis. I'm sure everybody's come across that at some point or another. And that was usually in high doses of these medications in an immunosuppressed patients, people who are on chemotherapy, who are at risk for it. If you're really concerned, I recommend seeing a dentist before you start. Do your dental work first, okay? Because dental work on top of these medications can create a problem, especially if you're at risk for it. Not the general population, however. This group called SERMs, we talk about selective estrogen receptor modulators. That's a big word. Basically, these are what I call kind of estrogen-like, kind of estrogen-not-like. These particular medications in some tissues act like estrogen, and in other tissues they don't like estrogen. For example, the one we think about a lot that's a SERM is tamoxifen, and anybody who's had a friend or a family member or a personal issue with breast cancer knows tamoxifen in the breast is anti-estrogen, so it prevents breast cancer. Raloxifene, for example, and also an estrogen, tamoxifen actually increases bone health. Estrogen makes bones grow. Raloxifene is a kind of a cousin to tamoxifen. Same thing, can helps with bone growth. The downside is it may have estrogen product-like activity, for example, in the uterus, which can cause uterine cancer. Estrogen also, as we get older, can be a bad actor to cause increased risk of blood clot. So that's some of the things you have to be worried about when you take an Avista. Do you have a risk for uterine cancer? Do you have a risk for blood clots? Okay. Calcitonin is a natural hormone that we give. It's not used a whole lot, very commonly, but it can be. Parathyroid hormone, or this Forteo, is extremely expensive. It is an injectable daily, like insulin, under the skin. It usually is limited to about 2-year usage because of the side effects and because it is so expensive, and likely if you don't see changes by then it's not going to get better. This is for your more severe osteoporosis patient. Okay. Estrogen, very commonly back in the day we used to put all women on estrogen, not only to control her moods and swings and flashing and this and that, but it helped build her bone. We thought we were doing her a favor, giving her good bone health. Now we've learned estrogen over a long period of time actually can cause complications such as breast cancer, heart attack, stroke, so it's not a benign medication. The theory now is the little amount of estrogen you can get away with for the least amount of time. Okay, that's kind of where we're at with there. Testosterone, this is not FDA approved for men. Remember, again, you gentlemen, I'm sorry we don't pay attention to you very much in this category of disease process, but if the thought is osteoporosis is secondary due to low testosterone, then you can consider adding that back. Okay, but again, it's off-label use, meaning that's not what the FDA is intended for. And again, testosterone can cause lipid problems, high cholesterol, acne, hair growth where you may not want it, so it has some side effects to it. I always say I should give this talk to teenagers because this is when the bang is in the buck. Okay, what we did when we were in our teens and 20s is going to affect us now. Now, it doesn't mean we can't help stay healthy with our bones, but if I could talk to people early on, just reinforce what we talked about, maximize their supplements, regular exercise, avoid tobacco, alcohol, and I would say the Diet Cokes in there. How many times do you see a teenager with a cup of coffee, which is so strange to me? These coffee drinks have all this caffeine in it, trying to get them away from all of that because it's leaching calcium from their body. And not helping them build bones. So this is where I need to talk to them about. Now lastly, fall prevention. Now just because a person has thin bones or osteoporosis does not mean they're going to actually have a fracture. Something has to happen to cause the fracture. And things that we don't think about on a routine basis is, what does our house look like? What does the environment that we're working in look like? So I say, if you could back up and take a survey and try to limit your risk for fall. That's probably one of the easiest and simple things you can do along with your supplements and your exercise. First thing is throw rugs, okay? Again, I'm from Minnesota. You walk in, everybody has a rug in front of the door, because what do you want to not do? You don't drag snow in the house, or you don't drag dirt in the house. My grandma she'd kill you dragging dirt in the house. Wipe your feet off. She's got that little bitty Indian weaved throw rug right there. And I don't know how many times I slipped on that as a kid. So watch those throw rugs, and you may even want to tack them down, double-sided sticky tape. There are rug grippers now that can help with that. You can even take a push pin. My grandma did after a while. She put a push pin through the floor. It's her floor, she doesn't care. So it doesn't slide up under her feet, okay? Electrical cords, especially if you've got cords running across the room. I went to go visit my mother, who, like I said, is 65. She didn't have her cable hooked up right for her computer. She had this long cable cord across her living room from the TV to her computer. I was like, what is this? My husband's an electrician, he fixed it for her, but I was like, this is like a nightmare for me. You're gonna break a hip. Routine eye exams, making sure your eyes are proper. If you need glasses, get them. I know it seems simple, but you'd be surprised how many people tell me on a daily basis, I need glasses. Do you wear them? No. Why? Well, I just haven't gotten them yet. Well, okay. And that even goes for sunglasses. You know, when you walk out into the bright area, the first thing we all want to do is squint. You can't see as well when you're squinting, and there might be a tree branch or something in front of you, and you've just tripped over it and you're outside. So thank you, he put his sunglasses on. So not only glasses, but sunglasses, okay? He's my prop, and I didn't even know it. Proper shoes. I'm not one to talk. I love my high heels. But good fitting shoes with a good support system to you is important. Lighting and clear pathways. Again, I love to throw my mother under the bus. I went out when she's in a Newtown home, and I bought her those little plug-in night lights, because she's getting up, going to the bathroom, and she's got these bruises all over her legs. So, oh, I bumped into this, I bumped into that. Doesn't turn a light on. I'm like, you live by yourself? Well, if I turn a light on, it breaks me up too much, and I don't want to be that awake. Oh my gosh. Oh, yes, she's killing me dead. Ambulation aids, she does do this now. I'll give her this. When she's out in crowds, especially where she thinks she's going to get kind of trampled on, so to speak. And if you saw my mother, there's no way nobody could trample over my mother. But when she's out shopping or in crowds, she usually brings a walking stick with her, because she feels she has better balance. People will knock and people don't realize it, but they just knock somebody over, and oh my gosh, I'm so sorry, and now we go to the ER. So really, ambulation aids I encourage. Also with bathing or with getting in and out of the shower or up and down from the commode. If you need something to help pull up, I always say there ain't no shame in my game. You got to get up, okay? So put that wall mount in there, whatever bracket you may need. Lastly, this is another thing I've had to talk to her about. She likes her Tylenol PM. When she gets up in the middle of the night to go to the bathroom, she's a little sleepy. Really limit or watch what you're taking at night, especially if it's long acting. Ambien is another notorious one. I don't know how many people say, I have no idea. I got in the middle of the night and I made a sandwich and did this, that, and the other. I don't remember a thing of it. She's nodding her head. Yeah. Be cautious of that, because you can quickly take a tumble with those medications without realizing it. Popper and Ollie. I say this is an accident waiting to happen. I was actually making this talk, and I had to laugh, because again, my mother, Arlie Mae, she sent me this picture. That's my mother's two dogs. This, you can't quite see, this is the door coming into her house. Nice tile floor. What do we have? A throw rug that has jute on the middle of it, and this fuzzy felt, because I've actually been on that throw rug, and it's slippery as all dickens right there. She has these two tiny dogs. That's Popper, that's Ollie. Popper's 17, Ollie's 1. They're like, Popper's 11 pounds, Ollie's 5. They're little dogs. Right here when you come in too, if that's not hard enough, where's my thing? She's got a plant on the floor. Why? Because that's where plants go, I guess, on the floor. And then she has this stand here. Now what you can't see is to the side here is an electrical cord, because she's got a lamp up here, which is okay, so she leaves the light on when she comes home. She knows that, the light's on. But the cord, instead of being behind this, is actually, and you can't even tell from this picture, it's in front. So I could totally see my mother coming in, arms full, winter coat on, boots on, little dogs coming to meet her, slip, boom, I'm waiting for it. I called my mother, I said, Mother, really, are you going to fix this, or do I have to come up there? She told me to hush. Shelly, hush, I'm fine. But this right here, all of this, to me, is an accident waiting to happen. And I thought, that's just, I couldn't have planned that better, other than having the sunglasses in the room. I mean, that was classic right there. And she's 65 and she has osteoporosis. And I just dread the day that I get the phone call that she fell. I do. Okay. As I said, I'm from Minneapolis. This is the Minneapolis Metrodome. This actually was opened up in the early 80s, 1982. Right here is downtown Minneapolis. Makes me very homesick to even look at it. But what happened last year in December 2010, I think it was the 12th or the 10th, I can't remember off the top of my head, the second week of December, they had a really heavy snowstorm. And I actually used to work at the Metrodome. I was a cashier when I was in college. And this ceiling actually should be poofed up like the Jiffy popcorn, okay? Because it's the air. It's the inside Metrodome. It's a cool place. They had such heavy, dense, wet snow that it fell in. It dropped the dome, literally. But when I looked at this picture, I thought, I don't think so. I think this Metrodome has osteoporosis. That's what I think. I think that this trabecular bone has gotten thin over time, and our cortical bone on the outside couldn't hold it up anymore, and it fell in. What do you think? That's what I think. There's that cortical, there's that snow up there. My other picture I had, there were people shoveling it off the Metrodome. So our Metrodome has osteoporosis. It needs a DEXA. This is the same snowstorm. I had to throw that in there because it just makes me, like I said, homesick. Crazy, I know. This is the car under there. Look at how heavy, that's just awesome. This was my favorite thing as a kid, King of the Mountain. We would play forever. This is from the snow plow. This is not just snow. The plow has plowed that up. And look at how much higher that is. You would climb all the way up there and stay up there as long as you could, pushing everybody. And as they come up, you push them off. Hours until I couldn't even speak. I'd be so frozen. Come in, have a cup of cocoa, back out I go. Makes me homesick. Okay, some references. And interestingly, October 20th, you didn't know it, is World Osteoporosis Day. I didn't know there was such a thing, but there is. They're coming out with a campaign, Love Your Bones. They're targeting, like we talked about, supplements, diet, and exercise, especially when your bones are growing. Hopefully we'll see some of this propaganda. This is from the International Osteoporosis Foundation and hooked up with the World Osteoporosis Foundation. Hopefully we'll see that come out. I just happen to look into my reading yet. I haven't seen it in the lay press or media yet, but that is, Osteoporosis Month is actually the month of May, but that's coming up. Okay, thank you so much. I'm sorry I went way over.